their beliefs and values, and looks at the managers facilitating and implementing person-centered thinking. So person-centered care planning, if you're using the nursing assessment and the assessment tools, it can't not be personal-centered, right? It just can't not, because it's not static. Each person has their own assessment with their own assessment needs. So person-centered care planning, when it came out, it almost seemed a bit strange, because it was a given that actually if I was interviewing a patient and selecting the right tools for them, it was personal centered. But here we are anyway, just to say that we've done it. Personal centered care planning is a theory and a recommended framework. So therefore it is appropriate in your endpoint exam that you can talk about it. Okay, so it is an approved method. So please bear this in mind, that if you do have a professional discussion, as basic as person-centered care planning is, this is absolutely an approved nursing intervention. Legislation related to person-centered, you can see on the screen there. In Canvas, you will have all seen that I've given you that drop-down list for laws, and that's because actually the same laws come up over and over and over and over again. In each activity, we generally have the same laws, which is health and safety at work, our disability ones, the Care Act 2014, and safe ways of working. So same laws come up over and over again. And I'm not going to cover those in this because it is online. So personal-centered values applies to the importance of the individuals, and obviously looks at kind of how they live their life in the way that they want to live it. And really, it's our job in our services to try and match that and support them as much as we can. Core values for being personal-centered is choice, independence, equality, and respect. And inside that, you've got your individuality under choices, because you can make unwise choices. You've got your rights, which relate to the human rights articles, the right to care, the right to treatment, the right to refuse care and treatment, dignity and privacy, the right to be treated humanely, and then respect and partnership. So it kind of all interlinks, doesn't it? And we know that partnership working is part of the multidisciplinary approach. Personal-centered care planning is literally designed as a way of exploring somebody's life and getting to common goals, looking at shared problems, understanding their vision, their purpose, and their goals, which is what you're going to be doing in that clinical assessment, and using all those assessment tools. Equally, it looks at the focus of the person's past, present, and their future life. So again, during your clinical interview, during your discussion, you could say, tell me a bit about your history. What is going on now? And where do you see that end of life bit? Where are we going in the future? So those discussions we're having, probably just not in this structured way, but they are being had, and that's what's important. And then equally, we then look at learning opportunities and developing stuff. It is all about working together. It's about those commitments and sharing those goals, being focused, and being focused on the person. Those assessment tools do that. And that goes back to, if you score 15 and it hasn't moved, what are we going to do? And it also looks about recognizing the people we look after, citizens, and their family members. And we know that family members and members of the community and churches have a lot to offer in relation to people's care, especially if they haven't got capacity to give consent. It's even more important if we have people with dementia who are unable to articulate for themselves, that we can get that sense of their identity from others. And that's what we're looking for in shared goals and visions. Obviously, we need to work together when we do that, and you'll all have different ways of capturing people's lives. Some of you will have life books. I don't know in the dementia service whether or not you have your life history story books, but it's normally those books that start from when they were younger up to now, and it gives their whole life history. The problem with those is they take quite a long time to complete, but they are a great assessment tool and do tell us a lot about the individual. The problem with personal-centered approaches, we've all got to work together, and sometimes that's not what happens in care homes, because you are normally either a key worker or the person that's just been told, can you do that care plan? And actually you can see there, when we all pull apart, we don't get what we want, but when we work together, we all get where we need to go. So person-centered care planning is very much a strategic operational thing where we need to communicate more effectively and bring people together. And that can be really difficult, especially under current climates, because you've got family members that you need to introduce, social workers, doctors, other professionals to come together to help to talk about this personal care plan. And that can be quite challenging to arrange. It can be quite time consuming. Have any of you been involved in where you've had successful care plan meetings where you've invited people and they've all come along, or has that just not been possible recently? Any examples?
I'm not dealing with that.
So you're not dealing with it at the moment. But if you were to deal with it, what I'm hoping you're getting from this is that sense of the planning, which is if somebody says to you, can you review Margaret's care plan? You can't just do it that day. Yes, I can do it, but who do I need to involve? And I've got to invite people. And therefore, it doesn't just happen overnight. These are tasks that take time to prepare and plan. So we're not going to worry about that activity. Principles and values. So there are 7 principles of person-centered care planning. We need to make sure it's individual, promotes independence, privacy, partnership, choice, dignity, respect, rights, equality, and diversity. And again, those core values, which we've already just spoken about, looking at those dignity and respects, offering coordination, care and treatment, personalising the care and support plans, and supporting people to recognise their own strengths and limitations. And that's that bit where we should be working with them. We've already said it's not a one hat fits all, and it's not, there's no quick fixes here. It is about the fact that humans are complex and we've just got to take a lot of information in for it to be person-centered. So how was person-centered care planning developed? Started in the 1980s, so it's not a new concept. However, theories go back to 1940 something with Percival, somebody or other, can't remember his name, but this isn't a new concept. And it was a tool that was designed for everyone to control or feel included in their care. And interestingly so, it moves away from the medical model of social care. So if we think about our theories and frameworks, the medical model was, we were the people that were looking after you. We told you what the best way was to look after you, and that's what we did. That's the medical model. And we've obviously moved away from that to a much more flexible model. So we need to just make sure that the benefits of the individual are focused in everything that they do. And outcome-focused care is a new concept that's coming in. There are multiple models to report and record outcome-focused care. I don't know if any of you have heard of the STAR model. Has anyone heard of the STAR models? The outcome stars? No, if you haven't, that's fine. I will put some information out on the outcome stars. So the outcome star, basically, it's a star. And as you go around the star, it's got the activities of daily living. And on each spike of the star, it's got a scale of 1 to 10. And it's a really simple tool. You plot where you are. So it does a nice little scattergram around the star. And as they are with you, you can see the diagram moving up or down. And there's a star for each health condition and for each mental health condition. So again, it's a nice visual tool to show recovery and health improvement. Okay, so the outcome stars are a really useful tool for outcome focused care. And equally, what it does is, if the star shows a point, maybe you're 8, a 9 or 10, and that's the maximum you can achieve on that point of the star, then you don't need to focus on it. So you only focus on the areas where it's lower. And therefore, what you're doing, you're targeting care where it is specifically required to improve something, and you're not working in areas where you don't need to improve it. Does that make sense? I'll forward you some information just so you can see it. It is a new concept, so therefore it's probably, you won't have seen much of it, but it's only being drafted now. We used to call it the recovery star in mental health, but they've now brought it across health and social care. Individuals have as much control over their choices. Again, outcome focused. What is it you want? How we're going to get there? And the plan is there to make the individual's life better, not to replace any existing services. So that outcome focused style works really well, because actually, if you are achieving in an area, then let's not plan for it. You know, we've got enough work. We don't need to do more work. So we're not going to do that activity just because we haven't got enough time today. Person-centered care planning looks at different areas, but equally, to get to somebody's goal, we need to look at the people, the health, the choices, the strategies, the barriers and supports, and that gets you to your goals. And obviously, we have the places to respect, hopes and fears and themes. So when we plan for people, we need to have hope, we need to have goals, and there needs to be something to strive for, because actually, if we plan somebody's care and there's nothing to strive for, what's the point? You know, we need to give people hope in recovery. Yes, you're going to get better, or yes, we can make your life less painful, or yes, we can reduce the symptoms of something, you know, because actually, if we're not providing hope and we're not providing recovery of some type, why am I in the care system? And actually, we don't do that in care planning, do we? We don't sit down and say, look, what is it you want to achieve? We tend to go, how can I just get you through the day? How can I wash, dress, feed you? So what's the hopes and goals? And hopes and goals looks at the strength-based model, and that's what CQC are now looking for. So obviously the benefits of working in a person-centered way is it puts the person at the centre of the process, it promotes their rights and choices, it gives full autonomy and independence. So it gives the person complete control. And obviously it looks at what the individual is capable of doing. The problem is there's multiple barriers to it. And that's obviously training, staffing levels, looking at trying to get hold of people, risks. So the reality is, if you're going to be serious about changing the way in which you conduct patient assessments and you look at the way that you write person-centered plans, you need to look at all the reasons why it doesn't work at the moment and try and overcome some of those obstacles. Because actually, introducing all of these new strategies into a care service could take quite a long time. So we need to look at how we can do that. Going back to what Shannon and Weaver, that theory about listening and understanding, it's important that we listen, sorry, that we listen and that we understand. Person-centered care planning is an assessment process, so we all need to think about and how we plan our lives. That's the activity of daily living. People have clear ideas about what they want to achieve from that. It's useful to plan in a structured way. Person-centered care planning is about delivering that, looking at different shared values across the organisation with the people, and who can help. You know, not everything in that care plan is going to be achieved by you in your care home. The reality is we've got a whole network outside of where we work. So do we need to do some social prescribing? Can we go to the community for stuff? Can we go to charities or groups? Or alternatively, is there green space prescribing in which we can do? So social prescribing for care homes, again, is a new concept because we generally keep it all contained. But the reality is there is so much more outside the front door that could be done, but people are exhausted and fatigued. So social prescribing gives you all of this support outside your front door. Who could I go to? Who could help me? What could we do to support somebody? So person-centered care planning is a powerful way to provide active change. It obviously supports working together, better way of listening, obviously much more interpersonal, and looks at shares and beliefs. It's not a one hat fits all. It's not just about putting things in paper. It's not just about routines. It really is about putting people at the centre. And the problem with social care is it is a changing landscape. You know, we can get there. It's just constantly changing. So the golden rules are: have aspirations, have hope, show in your care plan that there is hope for something. Because if there is no hope, what are we living for? Identify those needs, identify how you're going to achieve those outcomes, and then work forward. Planning looks at different models there. So you've got some different things there. So whole life planning, a focus on the individual teams come together, positive processes, identifying the dreams of the individuals and families. And then on the other side, the essential lifestyle planning, what is important to that person and essential for their life and their support. Looking at tools of planning and quality. So if we're going to write a care plan, who's quality assuring it? So making sure that they're written in a person-centered way, who's going to make sure that they're focused and that they have a positive outcome, who's going to be monitoring the changes. So again, behind your person-centered care planning processes, what are the quality assurance tools in which you're going to do to monitor them? And this really ties into your unit around quality assurance. And under quality assurance, how are you going to know that what you are writing is of good quality? So who in your home reviews your care plans? When the care plan's reviewed, how do you know that it's of good quality? And the reality is, if you're in an outstanding care service, CQC has deemed you to be outstanding. If you're in a good care service, it means you've got room for improvement. So who's going to quality assure that? Who's going to give you feedback? So the reality is, when you write your care plans in your home, you should have some way of rag rating them. So there needs to be an independent person that reviews care plans and grades them almost to say, you know what, this is a very good care plan. So those that write care plans, you would almost risk rate them. So you'd give them like a red, amber, green. So if you've written maybe 3 care plans and they're perfect, I'd give you a green rating and I'm not going to sample them. If you've written care plans and I think there's lots of areas of development, maybe I'll give you an amber and I'm going to keep reviewing them until you get them to the green rating. But if I read one of your care plans, I think it's absolutely appalling, I'll give you a reg rating of red and I'm not going to, I'm going to give you feedback and training to get you up. What CQC want to see under well-led is somebody is giving feedback on care plans that are written. Okay, because again, they must be internally quality assured. Okay, so just because you write it, you should expect feedback. So if you are writing care plans in your service, it is important that you go to your manager or the clinical lead and say, can you review this? Can you give me feedback? Because the reality is we're all meant to be on this internal quality improvement cycle. And the best way to do that is to rag rate them. And by doing that, when CQC come out or when NHS England come out to do clinical audits, you know that you've got a robust framework for care planning. Does that make sense? So you must have a policy and procedure for rag rating, internal training and internal governance, and you must get feedback. So if you are being supervised, please make sure in your supervision, you ask for feedback from your care plans or the assessments that you've conducted. Obviously, care plan, care assessment packages, person-centered care language, we've already said that is really important. You need to show the individual in their needs, that's fine. We do not group individuals by labels. So that's what we say about you're not an alcoholic, you're not this, you're not that, but you may just be somebody with substance misuse. Language is really important to ensure that we've got capacity. Equally, remember about the Accessible Information Standards Act. If you are writing a care plan for somebody with dementia, how are they going to read it? So therefore, does the care plan need to be in an easy read format? If you've got a customer who's got learning disability, because somebody in this group earlier said they've got some learning disabilities, your care plan should all be pictures. Does the care plan reflect the person in which it is written for? If it doesn't, you are not meeting the Care Act of 2014 and you are breaking the Accessible Information Standards Act that CQC is coming out to audit. So when you do a care plan for somebody, it is important it is written for the person, not for the business. Your care plan software may look lovely and it may look all glamorous, but if it is not designed for the person that's meant to be using that care plan, then it's not fit for purpose, is it? Because ultimately, The care plan is personal centered. It's their hopes, it's their goals, it's their dreams, and it's their direction of travel. And if they can't read it or they can't understand it, it's a pointless plan, isn't it? Because it's about empowerment. You can't empower somebody if they can't get to it. So again, we've already gone through this. We know that we've got our pre-assessment. What information do we have? The assessment, diagnosis, outcome, interventions, rationale, evaluation, risk assessments. Different assessment tools across all services. So this is just an example of a tracking document. You're all going to have your own templates. And when I come out to do your observations, you'll show me something that you've done. Okay, so you've got 9 weeks to do a care plan. So if you've never done a care plan, you've got 9 weeks before I come out to your home, because I'm going to need to see one that you've done. Person-centered thinking skills, strengths. So again, as we go through, we're going to look at the strength-based approach. And as we plan for stuff, we should be looking at how much they can do for themselves. What choice and control do they have? And this is going to link into that empowerment bit that we're going to do next after lunch. So the reality is, in care homes, we talk about empowering people, but our homes aren't designed to empower people. So we're going to talk about how we can do that. We know that we can empower people through education. We've talked about health promotions already, so hopefully that bit's done. But we're going to look at some other things in which we can do to empower people after lunch. There are different planning tools out there. Now, these planning tools are not nursing approved tools. They're not NMC, no, not NMC, they're not NICE guideline approved tools, but they are tools that are used in social care. So in social care, you've got what's working, what's not working. And again, I can send you, this will be in the document. But this is just a tool to go, look, that seems to be working. Why is that working? That's not working. Why is that not working? Okay, so that's a typical tool. 4+1 questions looks at why, and then trying to get to the bottom of something. Important for you is literally what it says. It's an assessment page which basically puts all of their priorities up front. So that's that interview technique that we were talking about, logging on. What's important to you today? So that's what we should be asking anyway. That should be the first question. Good day, bad day, really important, because we need to know what works well on a good day, but equally, what does a bad day look like? So again, those hopes and goals. Relationship circles, really important, because we need to know who we can draw in, and there's a document for that. Donut looks at what's important to them and starts to filter out. Communication tools is how you can communicate with the individual, and matching tools is about how you can get the right carers to the right patients, so how you're going to pair people up. So these assessment tools here are additional documents, if you wanted to use them, about social care, really, about trying to get this right. One-page profiles, again, really useful. I don't know if any of you still use these. They've been around quite a while. Do any of you use these in your services?
Yeah, I've got one.
Okay, so one-page profiles are lovely because it's that snapshot of information. When I was a home manager, I got all of my staff to do a one-page profile, and I had them on a notice board, because I thought, well, if you're going to share information about you, we should share a bit of information about us. And actually, for that matching up, what it meant is people could go, oh, look, you like to read Mills and Boon books. Well, I could talk to you about that. You know, you're only going to tell little bits about you. You're not going to go into your whole life history. Equally, if you put I like gardening on your one-page profile, then the people in the home that likes gardening can come and find you and talk to you about it. So one-page profiles are a really nice way for both ways, for sharing information from staff to patients, but equally patients back to staff. And it's really good if you're in a situation where you've got agency staff, because if you've got lots of agency staff, they're never going to read all of the care plans, are they? But actually, this one-page profile, which can sit on the back of the customer's door on the inside, gives you an idea about who they are. So that's where we need to be on one-page profile. So again, just lots of different designs out there. Just an example of one-page profile. when we go into the review, lots of different ways to review, but obviously, as we go through, you're just going to be looking at what's working, what's not working, and you've got the path way or the maps way of planning, looking at what's working well, what's admiring for them, what's gone well for the individual, or what has not gone so well, and what documents need to be reviewed. Again, you've got your making the action plans for your maps, and that's where you get to the back end of it and you start to go, look, how can we progress beyond here? And your planning for tomorrow and hopes, obviously, is really important, because if you don't have hope, there's no point providing care. And equally, they talk about the star in this one, but like we said, if you imagine the star as a model, you've got all of the things that are important around that star, and you start to work around it to try and get to people's hopes and goals quite quickly. Don't worry about that one. Don't worry about that one. Okay, so whistle-stop tour on person-centered care planning. Online, via your Canvas app, there is a video from the Social Institute Care of Excellence about person-centered care planning. You have got some handbooks, there's lots of advice and guidance on there. And I can promise you this is the last time I'm going to talk about person-centered care planning for the rest of the programme. So you'll be pleased to know you don't have to hear me go on about care planning after this session. Does anybody have any questions then? No? Okay, so when we get back from lunch, we're going to do enablement. So we're going to look at the trusted assessor model for enablement. And then after that, we're going to do intramuscular injections and end the day on IM injections. So end on something completely different, just to lighten the mood, because who doesn't like sticking a needle in somebody? So it's just me that likes clinical skills. So shall we say, what would you like for lunch? Do you want half an hour, 45 minutes? What would you like?
Half an hour, yeah.
Half an hour? Are we all in agreement? In a democracy, half an hour, does that work for everyone? So shall we say we come back for, what is that? Is that 1:10 past 1? I don't think my clock's right. We're all looking for a watch. See, I don't wear one, bare below elbows. 1:10 past 1.
Yeah,
Okay, so I'll see you all at 1:10 past 1. So you can log off and log back in if you like. Enjoy your lunch, everyone.
Bye.